Hello, my name is Joanna Stallings. I'm the MICU Clinical Pharmacy Specialist at Vanderbilt University Medical Center, and today it's my privilege to present to you on how implementation science can be used to facilitate ICU Liberation Bundle performance. So first, we are going to look at the electronic medical record system, EPIC. This is the flow sheet for the ABCDF bundle. And as you can see, it contains each of the different letters. So for the letter A, you can see where you can document the numeric rating scale. You can also document the critical care pain observational tool. For the letter B, the spontaneous awakening trial. We're going to go more in depth in each of these components in a moment. And then you can see the spontaneous breathing trial. For the letter C, you can see the Richmond agitation and sedation scale. For the letter D, the confusion assessment method in the ICU. For the letter E, early mobility, and finally for the letter F, family. This specific example is how Vanderbilt has implemented the ABCDF or ICU Liberation Bundle into our electronic medical record, which is EPIC. But one thing that we added was the ability to add the ABCDF flow sheet to the EPIC summary tab. So essentially how you do this is to navigate to the patient list activity, select the patient, and then search for the ABCDF bundle. And then you can actually select the wrench icon and type ABCDF bundle to make this a default report. And I've done this into my EPIC, which makes it really easy because all I have to do is click on that icon and then I can easily see the whole ABCDF report for that individual patient. So this is what it would look like once you add the ABCDF bundle to your summary activity. So now, as promised, we're going to start going through each of the different letters. So this shows the letter A and where the nurse would document either the patient's numeric rating scale for pain or their critical care pain observational tool. Now, your institution might use the behavioral pain scale or the BPS, but that would just be up to your institution to pick that option to implement in your electronic medical record. But as you see here, if the patient can verbalize their pain, then the nurse would document the patient's numeric rating scale. And if the patient was unable to verbalize, then they would document their critical care pain observational tool or their CPOT, and we do that at Vanderbilt every 4 hours. So next we're going to look at the letter B, so the spontaneous awakening trial or the SAT, and this has all the different components that the nurse would answer to considering the daily awakening trial. So first looking at, is the patient on continuous sedation or analgesia? So we have our nurses at Vanderbilt do this on every patient regardless of whether they're on sedation or not if the patient's on a vent. So if the patient is not on continuous sedation or analgesia, then they would put no and they're finished. If they are, then we would go through the rest of the different questions. So did the patient pass the SAT safety screen? So the nurse would put in yes or no, and reason for failure if they put no. So some of the drop-down choices would be, for example, if the patient was on neuromuscular blockade. Was the SAT performed? Yes or no. And if no, they would have a drop-down option to put why they did not do it. Did the patient pass the SAT? Yes or no. And if no, why they failed the SAT. So reasons that they might have failed. The SAT, maybe they got profoundly agitated, for example, would be one of the options that the nurse could document. So next we're going to look at the spontaneous breathing trial or the SBT. So this is what the respiratory therapist would fill out. So as you can see at the top, it would show the failure reasons for the SBT safety screen. So if the patient would fail the safety screen for that, for example, if their FiO2 was more than 50%. And the next part would give the respiratory therapist the opportunity to document whether or not they passed the SBT, and if not, why they failed that. So maybe they got very tachypnic, for example. Moving on to the letter C, and the letter D, this is where the nurse would document at our institution the Richmond Agitation Sedation Scale or the RASS every 4 hours, and then also the Confusion Assessment Method in the ICU or the CAM ICU every 4 hours. So as you can see here, they would document the patient's RASS score every 4 hours, and then they would document the patient, whether they were CAM positive or CAM negative every 4 hours. And it does list the 4 different parts of the CAM ICU, so whether the patient has acute fluctuation mental status, inattention, whether they have altered level of consciousness, and then also whether they have disorganized thinking, so that the nurse doesn't have to actually calculate that, but it would tell them whether the patient was CAM negative or CAM positive, so that can be a helpful component of this. This is another unique option that was added by Epic. So as you can see here, you can see visualization of the target RAS in the storyboard and a reminder when the order is needed. So on the left-hand side, you can see that the patient has a target level of arousal, so their RAS goal is -1 to -2. And on our second patient there, you can see there's an alert because this patient has a missing target level of arousal. This is an example of a best practice advisory or a BPA reminder to providers to order a target level of arousal. So in other words, if you have a critical care patient who doesn't have a target RAS, this would alert the provider that this patient needs to have one. So when we added this Epic-specific ABCDF bundle to our electronic medical record at Vanderbilt, some of the specificity of the ICU mobility component was new for us. One of the new components, as you can see at the bottom of this slide, was adding a target level of mobility for patients. So as you can see here on the right-hand side, that the nurse would document every day what was the patient's targeted level of mobility every day. You can see here that we also added in the mobility safety screen and reasons if the patient would fail that, and also the ability to document if the need was felt to proceed with caution, the reason for that, the targeted highest level of mobility, the achieved highest level of mobility, and early termination of mobility and why that would occur. So this shows why and gives the nurse the ability to document why that early mobility was stopped early. So the final component of the ABCDF bundle that we have enabled documentation for that was new for us was the family. So this allows the nurse to select what part of the family component was added. So maybe daily goals were discussed, or that the family participated in mobility, or they helped with delirium prevention or treatment. So lots of different choices that they could pick here, just how the family can be involved in the patient's. So one question that we're getting as different centers start to use this is, can you use what you already have? So we really encourage you to log into the Epic Foundation system and compare your flow sheets with theirs. So this shows you the number for the foundation flow sheets that you could potentially use for the different elements of the ICU Liberation Bundle. So one of the biggest questions, obviously, with this is how to implement. Thankfully, many of these records come from the foundation workflow. So most of your time is actually spent putting the existing records into your existing departments and profiles. It really takes about 3 months, 1 month for key decisions, 1 month to build, 1 month to train and to test it. And one important caveat is you need to have the February 2020 package or later to make this work. So there's so many different things you can do with this with regards to data collection. So one of the potential things that is coming is being able to track the SAT and SBT with a care path. So you can see whether or not the patient had exclusions to the SAT and whether that was performed or not in a picture like this. Also with reporting data, as you can see here for these 2 mock patients, you can see what components of their ABCDF or ICU Liberation Bundle was reported that day. So this isn't available yet. This will be coming after the PEDS build is completed within Epic, and that is hopefully going to be completed soon, and we will be able to compile our data and see how your specific institution is doing with regards to compliance with the ICU Liberation Bundle. I think all of us know, especially now with everything going on with COVID, how important that is to make sure that we get back on track with making sure that's done in our patients every single day. So now we're going to move on and we're going to look at Cerner. So this is an example of what the flow sheet will look like in Cerner. So very similar to Epic. So it just shows that where the nurse would put in the patient's pain scores, they would document the SAT, the respiratory therapist would document the SBT, they would document the level of arousal, the nurse would put in the patient's delirium assessment, and either the nurse or the physical therapist would put in the patient's mobility scores, and the nurse would document the family. So one of the biggest advantages of this system is, I can't speak to this about about Cerner, but Epic for sure. Before we had this whole flow sheet, I couldn't see the SBT and nor could physicians, only the respiratory therapist could. So this allows you to be able to see in one place all the different components of the ICU Liberation Bundle. So this is just another screenshot from Cerner, so showing you a few different patients. So once again, just in one place having the patient's pain scores, there's the SAT, SBT information, so that you can see that in one place. Cerner is also going to have reporting available. They have been partnering with SCCM to develop reporting, and they also have developed some process metric graphics to track target achievement and compliance dashboard to measure adoption. I'm going to show you an example of those momentarily, and currently testing is in place for this, and hopefully within the next few months we will have this available. So here's some examples of the compliance dashboard. So maybe it's overall bundle compliance, or how many pain assessments were documented, with the expectation being at least 6 pain assessments in 24 hours, SAT performance daily, SBT performance daily, documented level of arousal assessment, so at least 6 of those within a 24-hour period, delirium assessment, at least 2 of those daily, mobility and exercise safety screen performed, and lastly, family engagement. And this is some of the process improvement that we had talked about will be coming as well. So pain assessments with significant pain, patients with documented level of arousal assessments outside of the target. I think that's something all of us have seen, that maybe the patient has a target level of arousal of -5, which was appropriate yesterday, but now their actual RASS score is 0 because yesterday they needed to be deeply sedated. Maybe today they don't, so just making sure those are correlated. Whether the patient has had delirium in the past 24 hours, what was the patient's highest level of mobility, also family or surrogate, whether they joined in interprofessional rounding, and whether the family or surrogate took place in any task as part of the ABCF bundle. So in other words, did they help with mobility potentially? In conclusion, Epic and Cerner both have options to aid in documentation of the ICU Liberation Bundle. Reporting of compliance data is forthcoming, and pediatric documentation and compliance data is also being developed. Thank you for taking the time to listen to this presentation, and I hope this helps you to implement the ICU Liberation Bundle at your institution.
Hi, my name is Pat Posa, and I'm going to be talking about how to use the ICU Liberation Toolkit to facilitate bundle implementation. Research has shown us that through implementation of the ICU Liberation Bundle, we can see a decrease in next day mechanical ventilation, a 68% reduction in hospital death within 7 days, 65% decrease in next day coma, 63% reduction in next day use of physical restraints, a significant reduction in ICU readmissions, as well as in delirium, and the likelihood to be discharged to a nursing home or rehab facility. There are a number of resources available through SCCM to assist you in implementing the ICU Liberation Bundle. So you can see here is a picture of the ICU Liberation website. On that website, there are links to help you get started in implementing the ICU Liberation Bundle and an implementation toolkit. And that's what I'm going to walk through today, the different components of the toolkit and how you can use it to implement ICU Liberation at your site if you're just beginning, or things to assist you if you've implemented parts of it and want to implement the other parts. One of the resources available is a implementation framework binder booklet. And here it gives you a general framework for implementing the ICU Liberation, as well as a dedicated chapter to each of the bundle elements with strategies for successful implementation. This framework guide will provide strategies and tools to help you implement the ICU Liberation in your critical care unit. We know ICU Liberation is a complex intervention that depends on multiple steps, an interprofessional collaboration, and team communication. So creating that culture of ICU Liberation requires buy-in of multiple stakeholders, including administrators, clinicians, patients, and caregivers. So each of the bundle elements is a part of a larger bundle, and each element is synergistic with and relies on each other. Research has shown us that there's a dose effect. So as you improve, you can see improvement in outcome being achieved as the patient receives more elements of the bundle. As you're implementing the ICU Liberation Bundle, first of all, you need to pick a framework, an improvement model to use. Plan, Do, Study, Act, Johns Hopkins, the 4 E's. Next, gather a team. This is a team of interprofessional stakeholders, physicians, nurses, occupational and physical therapy, pharmacy, respiratory, unit leadership, and family members. You need to then understand your setting and your resources. Define which bundle elements you're going to start with. For example, before you can focus on mobility, it's important to ensure that your patients are awake enough to participate. So therefore, you might choose to introduce bundle A, assessment, prevent, and manage pain, and C, choice of analgesia and sedation, before you do bundle E, early mobility. If you want to decrease delirium, you might first want to address how you're managing the patient's pain and agitation. So bundles A and C might be also a prerequisite to doing bundle D, the delirium. After you decide which bundle element to start with and you go through the necessary changes to implement that bundle, you're developing your implementation plan, and then you'll develop an evaluation plan. So that's the general framework. And next we'll talk specifically through an example of what each of the chapters can provide for you related to strategies to successfully implement that bundle element. Each chapter in the toolkit will outline some of the general principles to implement each of the elements of the bundle. Starting off with first understanding the intervention. Next, understanding your ICU environment. What are the barriers and facilitators to implementing this particular element? And then applying the implementation framework to implement the element, that bundle element, by understanding your setting, personnel, support, facilitators, and barriers, and then developing your implementation strategy. Develop your practice guideline, develop an educational strategy, a rollout strategy, and develop a sustainable education strategy and tools for implementation. And then the final step in implementing is establishing your evaluation metrics. And there's a guide, a link to the ICU Liberation Minimum Dataset Toolkit that will provide you with a way to measure your bundle elements. So let's walk through one of the bundle elements using that implementation framework. We're going to pick E, early mobility and exercise. So you've done your gap analysis and you've identified that elements A, B, and C are going pretty well, but you have major gaps in E. First step is for your team that you've formed is to understand the intervention. What's the rationale for implementing early mobility? The evidence tells us it's safe, feasible in in adults and pediatric populations, and it improves patient outcomes. It's also cost effective. Next, you want to understand your ICU environment, both the key facilitators to mobilization and also barriers. So in your facilitators, you're looking at your ICU team. Do they have access to the resources and manpower that they need? Do you have specialized rehab therapists, access to them? Is there regular education on mobility? Have you prioritized mobilization as part of routine care? Do you individualize patient goals for mobility? For your patients, are they engaged? Do you have education in pediatrics? Do you have child life support? And your organization, do you have a mobilization protocol and practice guidelines? If not, this is something that you'll need to develop. Do you have the support personnel? Do you have staff training and education set up? Do you have the ability to have rehab consults? Do you have physical therapy order sets? And the appropriate equipment to mobilize your patients safely for them as well as for your staff. In understanding your ICU environment, you also need to understand the key barriers to mobilization. What's your unit culture related to mobilization? Are there safety concerns? What are your sedation practices? Remember, I shared earlier that sometimes you might not start with mobility if your patients are too sedated. They're not going to be able to interact and participate in mobility? Is there a lack of knowledge or training to execute mobilization? How about your patients? In understanding your ICU environment, are there any barriers in your patients? The instability of the patients, invasive devices, excessive sedation, non-compliance due to patient preference. So all of these things are barriers that you can overcome, but it's important to understand them and then to put in strategies to overcome them. Organizationally, one of the barriers is to not have the right personnel and the right equipment. And so that's something that you'll need to work out to be successful. How do you address some of those unit barriers? Well, first of all, create a culture of practice and promote mobilization through mobilization will prevent harm, and link that to organizational goals to prevent harm for our patients. Create a standard of care, and immobility is the exception. So we want our patients to be mobile. Establishing clinical practice standards, where you put this into your daily practice, where you set and discuss mobility goals. Maybe employ a checklist for assessment of readiness and safety to mobilize a patient, and then establish documentation standards. Schedule mobility events into your daily plan, coordinate activities with the bedside staff, and then establish a mechanism for family engagement in rehab. How do you utilize the whiteboard to identify what are the mobility goals and how much has the patient done today, and the family can be there to encourage. So we understand the intervention. We've identified facilitators to assist us in implementing the mobility element. We've identified what barriers could be in place and put in interventions to overcome those barriers. Next, we need to apply that implementation framework. So understand your setting and resources, identify and engage key stakeholders. So your team should be developing all of this. Establish roles and responsibilities of the different members of the team. Who's going to do that each shift assessment of a patient's functional status to be able to identify what that patient can do by themselves or what we need to do with the assistance of equipment. Also important to obtain institutional leadership, support, and endorsement. And then evaluate your system-based and unit-specific barriers. So the final step in applying the implementation framework is to develop your implementation strategy. Assess the current state of practice and determine how this bundle will tie in with the other ICU Liberation bundles. Tailor that early mobilization bundle and guidelines to the needs of your units. Develop a rollout strategy. What is the timelines? What's your format for rollout? Are you going to have an awareness campaign, videos, flyers, and set specific timelines? Then before you roll it out, you want to be able to develop a sustainable educational strategy. Learning modules, resources, tools, resources, checklists, that timeline for the educational rollout, and what's your ongoing for new learners as you onboard, what is the educational process related to mobility, so that as staff leave and new come, you continue to share that knowledge and set those expectations. So as we talked at the very beginning, you want to have an improvement framework that you use to assist you in implementing each of the bundle elements. And here's an example of a plan, do, study, act cycle related to early mobility and exercise. So your plan is you're going to develop a plan to test the change. So you have your interprofessional team. Your group has defined the mobility protocol. You've brainstormed and planned screening and criteria to be that it's safe for mobility, as well as when to stop. You've outlined the roles and responsibilities of the team. You've discussed communication and coordination challenges between different team members to be able to achieve a mobility session. And you've created a plan to implement that mobility protocol. So set an initial goal to mobilize one patient in the next week. So now the do is execute that small test of change. actively screen the unit for someone who's relatively healthy, stable, to start with your mobility protocol with. And you might even be able to walk this patient in the ICU based on their stability. So from admission throughout that week, apply the protocol to the same patient and see how the patient can progress through the week. Now we want to study how that went. So set a time aside to analyze the data and study the results. So meet with the team, debrief the experience. How did the protocol hold up? Was the screening okay? Was the criteria too restrictive, too specific? Was it too vague? How did the communication go between nursing and the rehab team, nursing and technical staff? How was the protocol integrated into rounds? Was the daily progress discussed? What could be improved? What was the documentation like? And then the final step is now you're going to act. What did I learn? And based on what I learned, what do I need to refine? So do I modify the protocol, adjust the screening criteria or the stopping criteria, the communication plan, or our documentation? So there's an example of applying that implementation framework of Plan, Do, Study, Act for mobility. The final component is to establish those evaluation metrics. At the patient level, you want to ensure standards for monitoring and document patient assessments, interventions, and their responses. And at the unit level, you want to be able to know what's the highest level of mobility achieved during a shift. And so here's an example in adults and in pediatrics, what that highest level mobility. I also refer you to, again, that ICU Liberation minimum data set toolkit that has metrics for each of the bundle elements, how to measure, and then a Excel spreadsheet where you can collect data and put it in and get your compliance. Once you've implemented the different components of the bundle, and here we're talking about the mobility component, it's important to continue to promote that bundle uptake and compliance. And some strategies to do that are to set daily patient goals for mobility, ensure your activity order sets don't promote bed rest, right? So get bed rest off of the order set. Force function for specific activity restrictions, employ routine and early rehab therapy consults. So if someone's on a ventilator, second day, automatically have therapy come in and evaluate the patient. You want to do some process observation. So you want to round to see how the bundle is going and monitor the individual bundle compliance, and then your patient outcomes. And then share that data, report unit performance on a regular basis to your team and to the unit. Sustaining your gains is important and hard, but some strategies include ongoing evaluations, so continue to refine your processes, Plan, Do, Study, Act cycles. Also schedule monthly meetings with your team, talk about mobility, share the metrics, and identify where there's opportunities for improvement. Celebrate, have mobility month, tell patient stories, designate mobility champions that can continue to spearhead the work. Compare your unit performance to other benchmarks. And most importantly, provide ongoing education. Share new evidence, engage in research, ensure that this education is part of onboarding of new staff. COVID has surely impacted how we have cared for our ICU patients over the last couple years through the pandemic. Our COVID-19 patients have required more sedation than the typical ICU population, which has resulted in increasing delirium and less mobility. We've often applied some of those same sedation strategies to other patients when maybe it wasn't necessary. We've seen this significant impact from not having family at the bedside in assisting in the care of the patient. And we've seen significant staff turnover and shortages. Most organizations are having to do a reset, re-educate and reestablish ICU liberation practices. ICU liberation is a complex process and lots of multi-element bundle. and implementation of this bundle can radically affect an ICU and a major change for an organization. Hopefully today I've shared with you what tools are out there and available for you to assist in implementing the ICU Liberation Bundles. We have the ICU Liberation Implementation Framework, also a reference, the ICU Liberation book, 2nd edition, as well as the minimum dataset toolkit for the ICU Liberation Bundle. I hope all of these tools will provide you with the support and guidance you need to bring ICU liberation to your ICU. Thank you so much for your time and attention today.
Good afternoon, good morning, good night, depending on where in the world you're watching this video. Welcome to the 51st Critical Care Congress. I so wish that we could all be together in Puerto Rico celebrating this wonderful Congress, but unfortunately, we're here on video instead. My name is Michelle Ballas. I am currently the Associate Dean of Research at the University of Nebraska Medical Center, College of Nursing. And I am here today to give you a presentation regarding how you are going to collect, measure, define success, know that you're doing what you should be doing, proving your worth. But really, what we're going to discuss today is how we're going to use data to facilitate implementation and sustainability of the ICU Liberation Bundle. Before I begin the presentation, I would like to just pass along my personal thanks for everything that you guys have done for your patients and colleagues in the last, I guess we're going on 2.5 years now. My hearts are with you and my prayers daily, thinking of you and all the work that you've done in terms of your critical care practice. So I thought I would divvy up this lecture in a way that is more kind of like tip focused. So kind of things maybe you could take back to your actual practice when you're going to implement the bundle. Again, now that we're regaining some sense of normality, recognizing not perfect sense of normality yet, but some sense of normality back in our ICUs. So the first tip that I'm going to give you in terms of data collection with the ICU Liberation Bundle is to stop. So before you go and start collecting and measuring data, you really need to define the things that you're measuring. Sounds simple, right? But we know that the ABCDF bundle, the ICU Liberation Bundle, does have a lot of different parts. So the first kind of tip that I'm going to give you is don't reinvent the wheel. We recently, the Society of Critical Care Medicine, conducted the ICU Liberation campaign, and it involved, I think, 68 adult intensive care units and some really highly motivated pediatric colleagues as well. But we've done a lot of this data measurement definition work for you. So with the SCCM ICU Liberation Collaborative, we did define the individual ABCDF bundle components. Within the collaborative, the A, the assess, prevent, and manage pain part, we defined the A part as a patient in the ICU had at least 6 pain assessments per day. And those pain assessments occurred using one of the valid and reliable instruments that you see on the PowerPoint here. So either the numeric rating scale, the CPOT, or the behavioral pain scale. All right, so the A, when you're going to define, before you measure A, it is focused on the assessment, prevention, and management of pain. And we operationalized how frequently those assessments should occur to be at least 6 times a day. The B in the bundle is both spontaneous awakening trials and spontaneous breathing trials. And obviously the SATs were defined as being performed daily on patients who were receiving continuously infused sedatives, so both analgesics and sedatives, or if the patient, and I think this is rather rare, but should a patient be ordered pain medications every hour or every 2 hours around the clock. Regularly scheduled sedatives were also considered in the SAT definition. SBT, we wanted SBTs to be performed on all patients requiring invasive mechanical ventilation. And obviously those SATs and SBTs, it's beyond the scope of this presentation, but we want those coordinated, right? We know the best outcomes come about when the sedation shut off before the spontaneous breathing trials are performed. But at least once a day, a patient on a continuously infused drip had their sedation shut off and had an SAT, and all patients on the mechanical ventilator that were eligible, that were on the mechanical ventilator, had a breathing trial once a day. The C in the collaborative was focused on the choice of analgesics and sedatives. That was a little bit harder to operationalize. So during the collaborative, we decided the C will be measured as the frequency and level of arousal assessments. So meaning how many times a day did the patient get their sedation assessment? We use the goal of at least 6 level of arousal assessments per day. And similar to pain, we want those assessments to occur using valid and reliable tools. So the RAS or the SAS. The C also component of it, although we didn't really measure it as much, but the goal being, we want light levels of sedation, and also it's great to set target levels of sedation. But operationalized, it's that they got those 6 level of arousal assessments daily. The D, the frequency of the delirium assessment. In the collaborative, we operationalized that they should get at least 2 delirium assessments per day on all patients, on the vent, not on the vent, all patients should have the delirium assessments. And it's the same thing actually with C. That's one of the frequent questions that I get is, well, how often should the patients on the ventilator get, how often should we document their level of arousal versus how many times should we do it? For consistency's sake, we just kept the number of assessments for vent and non-vent the same, right? So the D, again, 2 delirium assessments per day using the confusion assessment method or the intensive care delirium screening checklist. The E, wow, this was a rather controversial one, but how are you going to know your patient got the E? Well, in the collaborative, we had a lot of great back and forth discussions, but in the collaborative, we decided that the patient got the E if they had mobility activities that day that were higher than active range of motion. So if a patient received passive range of motion, active range of motion, or on a bed, or you're just turning them, that doesn't count as early mobility. We defined early mobility as that it was documented that the patient at least dangled at the side of the bed, or was actually up walking in the room or in the hall. All right. Finally, our F, we operationalize family engagement empowerment, meaning either a family member or significant other came and visited the patient and was educated on the ABCDF bundle, or that family or significant other participated in rounds, conference, plan of care, or ABCDF bundle. So either of those would be counted as the patient received the F that day. Now, again, I said a lot of this work has been done for you. This is a great resource for you. This is the SCCM's Adult ICU Liberation Minimum data set already here. It's on the website. I think it's on the website. That gives you a data collection form with some of the definitions that I just described. Some of them might be a little bit different, and you'll learn that some measures might need to be tweaked for your individual ICU based on where you are and where you want to go. But again, if you look at this form, and we won't go through all of them, but you see the A here, it just asks on this data collection form the number of times a pain assessment was documented using any of those measures that I mentioned before, so the self-report or the behavioral pain schedules. And then after that question, the follow-up question, again, just for this element would be, out of all those assessments, how many of them were significant pain? Because you might have a quality improvement initiative in your unit, right? Ongoing quality improvement initiative in your unit that might looking at, a lot of patients are having pain. What can we do about it? Well, you'll need to know how many patients were having significant pain. So great resource for you here, already developed, that you could peruse, and it does go through each of the elements of the ABCDF bundle. So tip 1, clearly define your bundle. Clearly define what means the team members did the bundle. So again, just because it's the A and it's the easiest to go to, our operational definition was A was a success and A was given if they had those pain assessments. The next thing, my next tip, there's a lot of controversy surrounding, what's more important, performance or compliance data? And it's beyond a theoretical discussion, to be honest with you. So we know that parts of the ABCDF bundle, the ICU Liberation Bundle, many of them it's recommended that you have safety screens before, right? So before we shut off a patient's sedation and do an SAT, we do a safety screen to see if it's safe. Before we shut off the before we shut off a patient's ventilator, we determine if it's safe to shut off a patient's ventilator. Seems kind of common sense, right? But those safety screen criteria, they're important in that the measures that are in them may actually serve to inhibit your performance data. Now, what do I mean by that? So when I'm talking about performance, what I'm really referring to is more of a yes-no concept. So if you're thinking performance, you're thinking, was the patient eligible for the intervention and did they get it? You're not going to be thinking about safety screens at all. Performance is, if the patient's on a continuously infused sedative drip, did they get an SAT? It's a yes, no. There's no, not applicable, anything. They either, in the last 24 hours, got that SAT or they did not get that SAT. No judgment there. There might be a very good reason why the patient didn't get an SAT. Maybe they're on 100%, 20 a peep, pressors, the max. But that's not what the performance data is going to ask. It's just simple yes or no. Did the patient get the individual bundle elements? With that performance, we've defined, you have to think about, well, what being performed. Do you want to know if the entire bundle is being performed? If so, you want to know complete performance. And that being defined, they got every single element of the bundle that they were eligible for, right? Eligible meaning, again, take out that safety screen aspect of it. If they were on a drip, they got the SAT. If they were on the vent, they got the SBT. If they were in the ICU, they sat at the edge of the bed or higher, right? So all of the individual elements, they got all of them, 100% complete performance. We also know that you could then, another way of looking at it is you could look at it proportional, right? So how many of those bundle elements that they could have got, did they actually get? Because you might see as you develop over time in your ABCDF bundle performance, you get better over time, and they're getting a little bit more and more and more of the bundle. The compliance is very different. And again, I personally am not a believer in compliance because I've seen so many problems with having these safety screens with 25 criteria that the patient has to pass in order for them to have their sedation shut off. Most of them not based in evidence, that then serve to inhibit. But if you're a really big believer in that it's really important to capture that data about why they're not getting it, you might want to look at compliance data, right? So with compliance data, you're looking at yes, no, the intervention was received in those that were deemed eligible. So whoever deemed that person eligible to get it, meaning they passed those safety screens, they got it. Both, again, very important, but I think they both have very different reasons for existence. Excuse me for 1 second. Just go back here. All right. and this is why I say they're both performance. If you look at the big outcome paper from the SCCM ICU Liberation Collaborative, so when we looked at those 68 ICUs and we looked at performance, and that's, I think, what we reported in that paper was mainly complete and proportional performance. So simple, yes, no. Did the patient get it? Again, not looking at whether it was, safe or not. We found that every, except pain, every outcome that we looked at got better with complete performance, right? Patients more likely to go home, less likely to die. But we also observed, so it was great. The best outcomes were if the patient got the complete bundle, they got every element that they were eligible for, they had the best outcomes. The good news is we also saw improvement with proportional performance, meaning the more bundle elements the patient got, the better their outcomes. And again, this is, if you haven't looked at this paper, if you just look at the consistency of results, it's just absolutely amazing to see the consistency in terms of proportional performance. So for example, if we're looking at ICU discharge, the more bundle elements, so they're down at 33%, they got a third of the elements that they were eligible, the third of the elements that they were eligible for, they had better earlier discharge, right? 60%, even better. 100%, even better. And it's the same thing with, again, all those outcomes. Look at death. Right? And this one's a little bit opposite because you want less than one to be favorable. But the more bundle elements that the patients got, the less likely they were to die. So both complete and proportional performance have been strongly demonstrated to associated with improvements in a number of patient outcomes. But that's, again, could be another 7-hour lecture. Another really fascinating thing that we observed, and when you're considering your data collection efforts too, this might be a little bit heartwarming. And again, we all acknowledge what a big setback we're taking in our ICUs during this pandemic, right? We know that we've lost years and years of improvement in terms of evidence-based ICU care delivery. But this might be a little bit good news for you, right? So we looked at, we asked the question of whether participating in the collaborative led to increased bundle performance. And in fact, it did, right? We had these great changes, and you can see that on the top slide. And again, it's illustrated in the proportional performance. But when you're looking at that complete bundle performance, we made really great progress. If you're looking at that the flat line, and then the sloped line, we made slow and steady progress, right? Isn't that beautiful? You see that? It's going up and up and up. Each month it goes up and up and up. It's great. Almost tripled, right? You're looking at, we almost tripled ICU performance. So if you look, we were starting at like 3% there and went up to 12%. Oh no, so that's even higher. Anyway, the point being, you can see this nice steady increase over the months in complete bundle performance. Unfortunately, when we're looking at that complete, you can see even in these highly motivated, wonderful, progressive, all-in sites, over that period of time in the collaborative, we had that improvement, but that improvement was indeed slow, right? And there were still really great opportunities to make some more improvements. But slow and steady, they say, always wins the race. Tip 3 with data collection. In addition to those measures that we just talked about that you will, as a committee in your hospital, think about what's most important for you to capture, I'm also going to throw a couple other variables out there that we've been finding based, again, on some analysis that we're currently still doing on the ICU Liberation Collaborative. It's just the gift that keeps on giving. About some other things that you might want to consider in terms of data collection. So tip number 3, we're going to consider some patient factors that might affect your ABCDF bundle performance. So this is paper that might be published by the time you're watching this slide. It'll be published in CHEST. We asked the question of, we wanted to know what are the factors that were associated with SAT and SBT performance, right? So everybody has their ideas of why people get SATs and why they don't, but there was really kind of gray area in terms of objective data. So we took the data from the ICU Liberation Collaborative and we asked, what factors are considered with next day SAT or next day SBT performance? And we won't go through all of these, but you can read the paper when it comes out. But some of the things that we found that you might want to consider when doing this data collection is in terms of, you know, if your performance might be low, there might be a reason for it, or things that you might have to modify later. Things that we found associated with next day SAT performance was age, and SBT performance was age, BMI, and diagnosis, right? So not really too surprising. The diagnosis came up there. You know, the sicker you are, less likely you are to have that SBT perform the next day. The age was a little bit counterintuitive as well, meaning that the older people we found were actually more likely to have a SAT and an SBT than the 18 to 39-year-olds. So that was kind of surprising. So think about the patient population, obviously, that you're dealing with. We also want to consider some practice factors, right? So we talked about that significant pain a little bit, but we did find that an episode of having an episode of significant pain actually was associated with a lower chance of having that SAT performed the next day, but higher chance of having that SBT. Pretty consistent. We did find if you're in a deep sedation, if you're deeply sedated or in a coma, so again, your RASS is -4 or -5, guess what? Next day, you think you're more or less likely to have an SAT or SBT. Much less likely to have both. But again, the importance of, if at all possible, avoiding deep sedation. Well, that's, you know, deep sedation. Interestingly, we also found some practice-related factors were associated with having those SATs and SBT performed, right? So patient being physically restrained, I hate to say this and it breaks my heart, but those, and I'm not in any way advocating, and I never will to the day I die, applying physical restraints, but we did find, you know, an association between physical restraint use and the increased SAT, next day SAT and SBT. Look at this though. This is probably the most amazing thing to me, because we toiled and toiled. How often should we do level of arousal assessments? How often should we do pain assessments? How often should we do delirium assessments? And honestly, don't tell anybody, we kind of made it up. Because there wasn't a lot of good data, right? We knew deep sedation bad, light sedation good, but those definitions were kind of all over the place. This to me is fantastic and really intuitive to me. But what we found is the more often that level of arousals were assessed, the more likely the patient was to have an SAT and an SBT next day, right? And if you were only doing those level of arousal assessments 3 times a day, the odds of having that SAT and SBT went down the drain. So when you're thinking about your protocols, please do consider how frequently you're doing your level of arousal assessments, and the same thing for delirium, right? Again, we guessed, so we said, let's do 2. So that's how we operationalized it. And we found that actually, you know, the more frequent delirium even assessments were associated with better SAT and SBT performance. So, you know, those two, that finding alone is really pretty fascinating to me. Finally, as I said before, you know, the C, as we define the C, really does refer to choice of analgesia and sedation. However, to operationalize that would have been a nightmare to do with 68 different intensive care units. So we chose to do that, you know, are they getting their level of arousal assessments? But clearly the meds patients get during their ICU stay matter, right? medications matter, and we know that. And Patty's guidelines pick them up. We know what meds are good or bad. Some people have their babies and love them more than others. But what we found was actually, again, pretty consistent with the literature in terms of benzos. Benzo's bad. There's a reason there's a B in benzos. Benzo's bad. No, again, not for everybody. I know some people need them. They're on them. Alcohol withdrawal. I get it. But in your head, if you think benzo bad, ballast, you might think twice before doing that 2 milligram IV Ativan push. Anyway, so if they got benzos, less likely to get the SAT, SBT. Propofol, you see, more likely. Dex, more likely. Ketamine, less likely. I have a bias against ketamine. I don't know why, but we did find in this analysis that ketamine, they were less likely to get both the SAT and SBT, and also your typical antipsychotics for your SAT. So kind of neat stuff to think about in terms of other data you might want to collect while you're going away. So my last tip is to ask the right data-related questions, right? So ask the right questions. Do I have the right tools, right? Is your ICU using the right tools? Are they using those tools? And again, I know it's hard, and we fought with many ICUs. You know who you are out there. About why these recommendations were made. But the current evidence did say that the ones that are recommended in the Patty's guidelines were shown to be valid and reliable. Again, you have special circumstances depending on your patient population, but the recommendations in the Patty's guidelines in terms of the tools you should be using are really the most up to date. Do I have the right frequency? And you saw that. Amazing, groundbreaking news. There's a reason we do these assessments. Do I have the right frequency? Am I doing the level of arousal, pain assessments, delirium assessments as often as I should? Am I doing them the same frequency for both vent and not vent patients? Sedated and non-sedated patients. Am I doing my SATs once a day? Some ICUs are doing SATs and SBTs 2 times a day. I am not aware of any data showing that doing them twice a day is any better. If we could just get the once a day up across the nation and across the world, I'd be gleeful, and I could retire and do what I really want to do, which is just snuggle with my new Shih Tzu. But do you have the right frequency for your SAT? Are you burning everybody out by making them do these SATs and SBTs 2 times a day for no reason? Just think about it. Do I have the right standardization? Am I training people the same way so everybody's talking the same common language? Those safety screen and success failure criteria. Oh, I don't have it on here, but I should have made it tip number 7. Get rid of unable to assess on every form. Trust me, you'll thank me later. No options for unable to assess. But do I have the right safety screen and success failure criteria? Again, go to the evidence. I'm not going to tell you here what the evidence is, but when you're making those safety screens, base it on evidence. Check your policies and procedures. Ask yourself, do I have the right policies and procedures? You will be shocked when you see how many of your policies and procedures contradict each other. Do I have the right educational modalities? Are my trainers trained? How am I doing the education? We found a lot of ICUs reported that teach back or those spot checks, super duper duper important. If you have the absolute luxury of having a clinical nurse specialist or another clinical nurse leader who can take on this kind of initiative, that would be fantastic to do those spot checks. So I'm going to tell you, your RAS score -2 is a little bit different than my RAS score to do the spot checks. And do they have the right people? We know, and we all acknowledge exactly how much time, treasure, and talent it takes to provide our patients the best care. So asking yourself, do I have the right people at this moment to even make a big push to get this done? You need the right people, including your IT support, who's going to help with all of your data collection hopefully, efforts. Hopefully all this will be extracted from the electronic health record. And there's another wonderful presentation that you'll be getting about from one of my colleagues in this session about all the stuff that's already built in. Again, don't reinvent the wheel. And that's it. That's the tips that I have. But again, the rest of this symposium is going to be fantastic and very, again, hopefully pragmatic, building on kind of the stuff that I mentioned, particularly with how to capture this data in electronic form to save yourself a lot of time and effort. Thank you for inviting me to be here. I so enjoy and I so miss you, and I can't wait to see you at next year's Critical Care Congress. I forget where it is. Hopefully it's somewhere warm. Have a great day, guys.
Hello, everybody. My name is Joan Brown, and I'm currently the Associate Administrator of the Clinical Operations and Business Intelligence team in the Value Improvement Office at Keck Medical Center of the University of Southern California. It is an honor to join the panel members that have presented to you thus far on leveraging data to facilitate the implementation and sustainability of the ICU Liberation Bundle. In my session, we will review incorporating bundle metrics into the EHR, essentially outlining the use case of our team's creation of performance reports from the data warehouse, then our study which assessed the impact of using performance reports with data literacy training, and then closing with our partnership with Cerner and testing the canned reports from Cerner's Healthy Analytics platform. We started in 2018 when Keck's Critical Care Institute established the AF bundle as a standard of care in the ICU following the surgical ICU's participation in the ICU Liberation campaign. We began a 4-month interprofessional planning effort, which included working with a technical team to develop algorithms and a data extraction approach from the data warehouse. During this time, the planning team designed a study aimed at understanding the effect of A through F bundle, clinical education, with data literacy training and performance reports on staff compliance. In 2019, we implemented the A through F bundle starting with 4 of the 8 ICUs at Keck, using a stepped wedged implementation design. Weekly compliance reports were sent to each unit, including analytical insights, as in which were the largest fallout elements and other key areas of opportunity to improve compliance. In 2021 to today, we implemented the A through F bundle in all 8 ICUs at Keck and shifted our reporting frequency to monthly reports for all units. The reduction in frequency was due to competing priorities for the non-IT department-based analytics resources. At the tail end of 2021, we were identified as a beta site tester of Cerner's A through F bundle standard reports that leveraged the SCCM's core measures. We will go in detail into this effort in comparison with our original effort to create our own set of A through F performance reports using our data warehouse. We used a 4-month implementation approach where the first month focused on interprofessional and role-based clinical education. Month 2 consisted of monitoring and auditing A through F bundle compliance following the clinical education. Month 3 began data literacy training and the introduction of weekly compliance reports, where month 4 was like month 2. It was monitoring and auditing of the A through F bundle compliance, but this time post-data literacy training. We continued to supply the units with weekly A through F bundle compliance reports for the duration of a year. The implementation approach included establishing a culture of team reflection on performance to establish a learning and change environment. Performance reports were created by the technical team from the Clinical Operations Business Intelligence Unit, a non-IT department analytics resource of Keck Health System. This included a technical leader, an ICU nurse clinical informatics leader, a technical project specialist with expert knowledge on data extraction from the data warehouse, and an analyst with advanced analytics and visualization expertise. We began the creation of our performance reports partnering with the interprofessional team to determine the standards and protocols that were necessary for A through F bundle implementation. The technical team then performed a gap analysis to identify discrete versus non-discrete variables. The interprofessional clinical team, together with the technical team, created workarounds or proxy measures if a variable was non-discrete or really difficult to obtain. The technical team then devised extraction algorithms, created an advanced Python algorithm to clean and analyze the data against compliance protocols, then visualize the data in Tableau for distribution to the units. The joint team worked together to design reports that were action-oriented and provided a level of detail that would help support adherence to the protocol by the frontline staff. The interprofessional clinical team managed any change requests to report calculations or design. To bridge the clinical and technical language barriers, protocol algorithms were created in a map form to help the technical team design the scripts needed to extract data from the right place and compute adherence to the A through F bundle. Here are some examples of the algorithms created. Compliance performance reports were sent on a weekly and monthly basis. The monthly distribution included a view of key outcome metrics like ICU length of stay, mechanical ventilation hours, and incidence of delirium to help the clinical team understand the impact of the A through F bundle on patient outcomes. Here we have samples of the weekly compliance report on the left and the monthly compliance report on the right. You'll see in the weekly compliance report, we also included comparison metrics from the individual unit compared to all 8 ICUs' performance, along with an indicator of an increase or decrease in compliance with arrows. We also included a metric that showed how close the unit was to achieving full A through F bundle compliance, with a percent of completing 4 or more of the 6 elements required for full A through F bundle compliance. We hope this metric would give a sense of being almost there in terms of reaching full bundle compliance. We also provided a patient-level detail view of the compliance reports per week. The detail included patient name, date, who the clinical staff were assigned to that patient, and whether they were compliant that day with any given element. A green check mark meant that patient received the protocol for that element. A red X meant they did not receive the full protocol, and a gray circle meant there was no documentation for that element. This view was not meant to be punitive, but to help the nurse managers, nurse leads, and clinical educators understand systematic issues, and whether some individual nurses needed more education on an element, or if more resources were needed to help follow through with protocols given a patient's acuity. The implementation of performance reports included data literacy training for all clinical staff. Data literacy training was done using a snack and learn approach, where during a shift, the team would bring coffee and snacks and ask 3 to 5 members of the clinical team on staff at a time to come into the break room, have a snack, and learn about the performance reports. In the sessions, we reviewed bundle compliance algorithms, how EHR documentation informed the reports, and where exactly to document to get credit for implementing the A through F bundle. We emphasized how the performance reports were supposed to drive action, more specifically, how the staff should read it, interpret it, and what they can do. We left the team with job aids on both where to document and a summary of what the team could do to increase compliance for each element, as well as the A through F bundle as a whole. Our study's statistical model compared month 2 and month 4 monitoring and auditing months to assess gains in compliance. The study demonstrated that data literacy had a positive impact on A through F bundle compliance performance with statistical significance. Both clinical education and data literacy training increased full bundle compliance performance. Our observation of raw compliance demonstrates a clear increase in the A through F bundle compliance intervention group, which were the first 4 units to receive the A through F bundle implementation approach. This increase was sustained through the onset of the COVID-19 pandemic in the intervention group, where compliance dropped in the non-intervention group. With the implementation of the Cerner Healthy Analytics platform, our institution was offered the opportunity to be a beta testing site of the standard A through F bundle reports that were a design collaboration with SCCM and Cerner. We gladly accepted the challenge, as the use of the Healthy Analytics platform would provide near real-time access for frontline staff to monitor A through F bundle compliance. Our performance reports used the data warehouse to populate the reports and required manual analytics. This meant our team could only provide the reports on a weekly basis and retrospectively. This was a significant limitation to the bedside clinician trying to care for the patient and manage complex care plans while monitoring the A through F bundle compliance. Once we were granted access to the Cerner standard reports, the KEC technical team began a gap analysis to understand the difference between the Cerner standard reports and our customized A through F bundle performance reports. There were several calls and emails to help facilitate information exchange between the two teams. KEC's technical team's role was to validate the reports for accuracy, provide feedback on visuals, and give experiential context to what visuals elicited action from the clinical team to improve compliance. The Cerner team provided context and logic of the standard approach, detailed how the core measures translated to the back end, and revised the dashboard when it made sense to incorporate an edit that would affect all Cerner customers' standard A through F bundle reports. The Cerner team also assisted the KEC team in suggesting technical approaches to bridge any formula gaps between the Cerner standard reports and KEC's performance reports. The next few slides show screenshots of the Cerner standard report visual. This visual shows encounter level detail in aggregate by provider, financial class, and discharge disposition. This view demonstrates key patient outcomes, including length of stay, the top graph, mortality, the middle graph, and 30-day readmission, the bottom graph. This view visualizes key metrics deemed essential by SCCM to the ICU Liberation campaign. It includes top assessments per day, top delirium measures, top SBT, top family involvement measures, all by patient. This view shows A through F bundle process metrics, including key documentation targets, patients present with delirium, level of mobility, and more. The bundle compliance view shows compliance trend lines for the A through F bundle as a whole and each of the individual elements. A patient-level detail was added as a result of our feedback in the effort of being a beta testers. The patient-level detail in the Cerner reports now include patient name and the result of the element protocol. We are still actively in the process of validating Cerner's standard report and are using our monthly performance reports as an interim solution to provide A through F bundle performance data to our 8 ICUs. Our next steps are to work with the interprofessional clinical team to decide whether the Cerner standard reports can be used out of box or whether we need to do some minimal customization to have them reflect our more stringent clinical protocols. Customizing would require internal resources from the Clinical Operations Business Intelligence team and the KEC IT department. This concludes the review of our use case in incorporating bundle metrics into the EHR, from our customized approach using the data warehouse to partnering with the Cerner Analytics team to leverage their real-time standard reports. Looking forward to the discussion with our amazing team of panelists. Thank you.